Welcome to Module 2, and welcome to the reality of healthcare analytics. Data is everywhere, but insight is rare. In this module, we're going to pull back the curtain and look at the systems behind NHS informatics. How it's created, what it includes, how we access it, and how to treat it with the respect it deserves. You cannot become a great analyst by just knowing tools. You must understand the origin, meaning, and limitations of the data you're working with. So let's look into our data sources. The NHS is one of the most data-rich healthcare systems in the world. Each day, it generates over 1.3 billion new data points. That's 15,000 per second, covering everything from A&E arrivals to GP prescriptions, lab results to bed occupancy. But here's the catch. This data is fragmented across hundreds of systems and dozens of datasets. Your job is to connect the dots. Among the many healthcare datasets, there are 5 foundational datasets every NHS analyst should master. They each represent a different lens on patient care. Some are transactional, others are analytical. Some tell you what happened, others hint at why. Hospital Episode Statistics, HES, is the flagship dataset for NHS analysts. It contains records for every inpatient stay, outpatient appointment, and A&E visit in England, going back over 2 decades. In 2023 alone, HES recorded 17.4 million hospital admissions, 122 million outpatient appointments, 22.5 million A&E attendances, including details such as the diagnosis codes and procedures codes, age, gender, admitted and discharged hospital, consultant specialty, and much more. But here's the downside. It's not real time. There's a 60-90 day lag, so it's better for trend analysis, not immediate decision making. Secondary Uses Services, SUS, is your raw transaction stream. The data before it's cleaned, aggregated, or anonymized. Think of it as the live feed powering NHS finance, commissioning, and cost recovery. SUS is updated daily or weekly depending on the trust. It's used to calculate payment by results, PBR, so data accuracy here directly affects funding. SUS and HES work together. SUS is live and operational. HES is cleaned and historical. Referral to treatment, RTT, is the dataset behind the NHS's most scrutinized metric, the 18-week constitutional standard. It tracks a patient's journey from GP referral to first treatment. For example, in April 2024, only 58.3% of patients were treated within 18 weeks, well below the 92% target. Over 7.5 million people were on waiting lists. RTT helps answer, where are the delays? Which specialties are breaching? Are pathway milestones being met? But beware, RTT data varies heavily by trust and can be prone to clock start-stop inconsistencies. In the Emergency Care Dataset, ECDS, you'll find arrival mode, clinical observations investigations, treatment and discharge status. In 2023, over 25 million emergency attendances were logged. Just 58% of patients were seen within 4 hours. Against the 95% target, analysts use ECDS to model demand spikes, ambulance handovers, and breach causes. Now let's mention one dataset that sits in the many other valuable ones as our 5th foundational datasets. SLAM, the dataset that sits at the heart of NHS finance and contracting. SLAM stands for Service Level Agreement Monitoring. It's how trusts and commissioners track what care was delivered, at what cost, and against which contract. You can think of it as the monthly financial mirror of the activity you've seen in SUS and HES, but presented through a commissioning lens. This is the dataset used to raise queries, trigger challenges, and reconcile payments. Missed or miscoded activity here can mean hundreds of thousands of pounds lost or disputed. All of these datasets are underpinned by clinical coding. For example, you've got a raw patient record, which shows someone's admitted, diagnosed, treated, and discharged. But none of that data is billable until it's structured, coded, and grouped. That's where clinical coding and health resource groups, HRGs, come in. Let's break it down. So what's coded? Diagnoses using ICD codes, which stands for International Classification of Diseases. Procedures using OPCS codes, which stands for Office of Population Censuses and Surveys. Classification of interventions and procedures, consultant specialty, using treatment function codes. And this is configured with other fields to form a HRG. Every HRG comes with a national average cost and a spell level or procedure level payment rate, coding accuracy impacts 100% of payment. Under the national tariff audits show average revenue leakage of 2 to 5% per trust due to undercoding or misclassification. Analyst tips. Cross-check for code completeness. Empty or invalid codes cause HRG assignment failures. Let me show you how these datasets work together. You notice a breach in RTT for orthopedics, so you check HES to validate theater activity, and ECDS to look at associated emergency readmissions. Or your finance team flags underperformance. You compare SUS claims versus HES submissions and investigate potential coding gaps in SLAM. This is where the role of the analyst shifts from reporting to storytelling. Data isn't just for counting. It's for course correcting and making valuable decisions that drives real change. So let's remind ourselves of the key national datasets we have covered. 1. SLAM. Tracks activity and costing under service level agreements. Second dataset, SUS. The foundation for NHS data processing, primarily used for payments and commissioning. Third, we covered HES, which captures detailed records of hospital care, including admissions, outpatient visits, and A&E. Fourth dataset, RTT, monitors patient waiting times from referral to the start of treatment. Finally, ECDS provides real-time emergency care data to support urgent care delivery. The ability to navigate and communicate with these datasets creates a real advantage in healthcare analytics. Even basic awareness signals you're ready to contribute, and that distinction can make all the difference when breaking into the field.